We're going to talk about syncope, that is the loss of consciousness. I'm going to give you two models for you to understand syncope and then go through some of the highlights. Now this is going to be an MS3 level approach to syncope. If you want to know a little bit more, check out the intern content under syncope for more advanced knowledge. Let's start off with the tank method to kind of get a conceptualization of what might cause syncope. I see the brain and the body like this. There's a pump and a tank that pushes fluid up to the brain. It's a brain, not a butt. So long as the fluid level covers the brain, the person functions normally. But if for any reason anything breaks, well, the brain doesn't get perfused. The brain doesn't get perfused, the body is designed to fall over. The brain is still suspended in the skull, but the water layers out differently, such that it really didn't matter what the pump, the fluid, or the tank were doing, the brain gets reperfused. And that's actually one of the things that constitutes syncope. The return to normal function should be rapid. When they're upright, for some reason the blood pressure doesn't get to their brain, they pass out. And as soon as they go flat, they reperfuse. So what can go wrong? Well, the pump could break, the water level could fall apart, or the tank could get too big. Let's see what that looks like. If the pump breaks, the brain is still at the top, but the water level doesn't reach it and the person passes out. If the pump is working fine, but the tank's got a hole in it and all the fluid is falling out, that's no good. And then if the tank gets too big, even though there was enough fluid in the tank, now there isn't. I want you to see this as pump, fluid, tank. Now, a word of caution, if you go looking at ICU literature and trying to use this method for hypotension, you're going to encounter similar words that mean different things. This is my model for how I approach this. You're going to find similar terms with a different concept map in the literature. Let's look at an equation. Just in case this didn't work, the equation will show you another way to approach this. It's all about perfusing the brain. So the mean arterial blood pressure is going to be equal to the cardiac output times the systemic vascular resistance. Cardiac output is a product of heart rate and stroke volume. Stroke volume is a product of contractility and preload. We can go around this equation and see how it links up to our tank method. If there's a problem with the heart rate, either too fast or too slow, or a contractility, there's not enough squeeze, you're talking about problems with the heart, that is, the pump. Issues with preload are going to be problems with fluid. And problems with systemic vascular resistance, too much vasodilation, is going to be the tank. Okay, let's use these models as we approach individual diseases you need to consider. The first one being vasovagal. In vasovagal syncope, something stimulates the vagus nerve. When the vagus nerve gets stimulated, it dumps acetylcholine. Acetylcholine causes bradycardia and vasodilation. So you're going to take two hits, both the pump and SVR. The person passes out. So what causes stimulation of the vagus nerve? Well, the vagus nerve is in the brain, and it receives inputs from the carotids as well as the visceral organs. So the first way of getting vasovagal syncope is through visceral organ stimulation. This is the person who cough, 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 passes out. Or the old guy who has to sit down to pee because every time he does, he passes out. Micturition, defecation, cough. Some stimulation of the visceral organs leads to a vagal discharge. The second is the carotids, the carotid bodies. Boxers go for a jaw shot, not to shatter the other person's jaw, But if they connect just under the jaw where the carotid bodies are, it causes a massive vagal discharge and their opponent passes out. For people who are not boxers, and what you're likely to see in your test, is going to be people who pass out when they turn to the side or when they're wearing ties that are too tight. They stimulate the carotid bodies, which are overly sensitive, and cause a vagal discharge. And the third is psychogenic. Because the vagus nerve is in the brain, certain things like the sight of blood or an emotional disturbance, like a fight, in an otherwise young, healthy individual is vasovagal. To make the diagnosis, you could do a tilt table test, and that's actually the test that you would do if you had to pick a test. But in general, with vasovagal, you don't need to do a test because the answer is usually determined by the presentation. You'll notice that all of these things are situational. And they are reproducible. Every time I see my own blood, I pass out. Every time I get punched in the jaw, I pass out. And usually there is a prodrome. That is, they know the syncope is coming. To treat vasovagal syncope, you are going to use beta blockers. And at first, this seems backwards, right? We just said the problem is a vagal discharge causing decreased heart rate and vasodilation. Beta blockers would also cause a decreased heart rate, so how can this be beneficial? The way it works is that the vagus nerve is reacting to a stimulus. Something has caused the vagus nerve to think, wow, there's too much pressure, I need to lower it. There's an upsurge and then a vagal discharge, which causes you to pass out. The beta blocker blocks that initial upsurge, so the vagal discharge never happens. So, vasovagal syncope, stimulation of the visceral organs, carotid bodies, or psychogenic, situation reproducible, and a positive prodrome, treat with beta blockade. The second kind of syncope is orthostatic. And this one you're not going to miss, because the patient presentation is going to be orthostatic. When they stand up, they get dizzy. The diagnosis is made by getting orthostatics. There's a systolic blood pressure change of 20, a diastolic change of 10, or a heart rate change of 15 when going from a laying to a standing position, or they get so weak and dizzy they can't finish the test. If they're orthostatic, you do one thing. You give them fluids. If it resolves, then you know what the etiology was. They were just volume down. Intravascular volume depletion. If it doesn't, you need to consider some more of the rarer things. So what are the things that cause orthostatic hypotension? Well, there are two. The pathology is either volume down, which are the 4 Ds, diarrhea, dehydration, diuresis, and hemorrhage, or a dysfunctional autonomic nervous system. It's going to be things like diabetes, Parkinson's, and advanced age. The dysfunctional autonomic nervous system is going to be the really old person with orthostatics who doesn't respond to fluids. Give them compression stockings and tell them to get up and go slowly. Everybody else is going to have some sort of volume loss that gets better with volume resuscitation. The third kind of syncope is going to be cardiac, but we're going to break it into two parts. 3A is going to be mechanical cardiac. Mechanical cardiac is a problem with the valve. That is to say that when they're at rest, no big deal, but as they begin to do more, whatever valvular lesion they have prevents them from meeting the metabolic demand. So it's usually a valve. The patient is going to be exertional syncope. It's either going to be one of two things. It's going to be the young competitive athlete who passes out after a game who's got a murmur, or it's going to be the old guy going to shovel snow who doesn't usually do that and passes out. First one is hypertrophic obstructive cardiomyopathy. The second has aortic stenosis. Because this is a valvular abnormality, the diagnosis is going to be made on echocardiogram, and the treatment is going to be valve dependent. See Cardiology, valvular lesions, for more information. The other one, 3B, is going to also be the heart, but this is arrhythmia. The path, of course, is an arrhythmia. Fast rhythms, slow rhythms, anyone can do it. The problem with this type of syncope is that it is sudden, with no prodrome and no warning. Comes out of the blue, they're just gone. Generally, the arrhythmia aborts itself and they wake back up. You can try to make the diagnosis with an EKG, but very rarely do you capture the arrhythmia that's caused them to syncopize, because by the time they get hooked up to the EKG, they're already awake again. The rhythm went away. So what happens is people get admitted to the hospital so they can be observed on telemetry. That is a 24-hour Holter. You wear a device that constantly records your rhythms. Generally, this doesn't work either. So what you can do is go ahead and get an event recorder that they wear for a couple of weeks. In the moment, 24 hours, a month. The treatment is going to be arrhythmia specific. And we have lectures on arrhythmias later on in the cardiology section. Now, this doesn't really meet with our model, this next one, but number 4 is neurogenic. And neurogenic is a problem with the posterior circulation. And here's the thing. The patient with neurogenic syncope, that is posterior circulation, poor flow, is going to be sudden and have no prodrome, just like arrhythmia. But the incidence of this type of syncope is so low that you shouldn't even go looking for it. If you have a sudden onset syncope without prodrome, think arrhythmia, unless you have found a focal neurologic deficit. To diagnose this, you can get a carotid ultrasound, but the best test is going to be an angiogram. The treatment of which is going to be treat the vascular disease that's leading to the problem. Let's go back through it. Neurogenic sort of exists on its own, poor flow to the back of the brain. Mechanical cardiac is going to be a problem with contractility, pump failure. Arrhythmia, generally a heart rate issue, problem with the pump. Orthostatics is a preload issue, they're volume down or have a dysfunctional autonomic nervous system, and they need to be resuscitated with fluids. Where vasovagal is a situational reproducible syncope with a prodrome that affects both heart rate and SVR on vagal discharge. That's syncope.